Welcome everyone to another week here with Dr. McDougall, and I'm Gustavo Tolosa, and I am very happy to see everyone joining in. I'd like to know if you can see and you can hear all right, and hopefully the transmission is going well. At least it looks like it from my end. And of course, all of you, or most of you, know that yesterday was Dr. McDougall's birthday, and we want to say happy birthday to Dr. McDougall in just a minute. And I just want to say that it is ironic that the one who is giving us a present is Dr. McDougall by being here today and every week and giving his free time. And actually, it would be us who would need to be giving him a present. But Dr. McDougall, the present I think that we can all give you is a huge thank you for all that you have done for all of us and that you will continue to do, because you're only 70 years young. So hopefully there's many, many more to come, and you will continue to make a huge difference in people's lives and to save lives. And we just want to thank you. I can see everybody here is wishing you a very happy birthday. So welcome, and we're very excited to see you today. How are things going in Santa Rosa?
Well, this is the first time I've been 70.
That's right.
This is the first time I've experienced 70. And I have to tell you, 70 is old. It is old. But fortunately, Mary and I are functioning really well. And having a lot of fun with the grandkids. And so life is good. But, you know the saying, life is terminal. So I'm going to try and be as productive and have as much fun as I can between now and then. But yeah, to turn 70 years old, I could hardly believe that would ever happen. Really, when I used to think, let's see, when will I be 50 years old? Well, that was probably 1997. And, I never thought that age 50 would come, especially gracefully. And here I am 70, and it's still pretty darn graceful. Anyway, thanks for the happy birthday wish. And yeah.
Wow. There are people here that say, it's not old. I'm 75. I'm 78. So.
Yeah, right. Well, no, you know what? It does make a difference.
Yeah.
Time does make a difference, and you look at things from a different perspective. There was a time when I was afraid to talk about the things that I talk about. That was many years ago, probably 45, 50 years ago. Now I'm pretty unashamed to say pretty much what I want and what I believe. And fortunately, I haven't been corrected that often. So I must be pretty spot on most of the time.
Yes.
And that's because I've spent 50 years studying this.
Right.
50 years, can you imagine? Yeah, when I was 20, I started in this direction. But fortunately, it's worked out, and hopefully it'll work out for another 5, 10, 15, 20 years. Who knows?
Yes, we are counting them. When was Mary's birthday? It was just a few weeks ago. What's it, like a few weeks ago?
What was 2 weeks ago?
Mary's?
Oh, Mary was on April 30th.
Right.
She was 71.
Uh-huh.
So she's a year older than I am.
Like 71 at all.
Well, she's doing well too. Anyway, we're still enjoying life tremendously. There's some questions people asked last time.
Yes.
And just to kind of address those, I talked about how oil was absorbed in the skin when you put oil on the skin. And, I did a little bit of looking up. You could do your own. But there are oils that are considered drying oils, which are quickly absorbed from the skin, do not leave an oily feel. There's fast absorption, average absorption, slow absorption. So there's different rates of absorption of oils that you put on your skin. And one of the particular problems with oils on the skin is that they often contain environmental chemicals, and so these environmental chemicals get absorbed through the skin very readily. So,
right.
Anyway, oil is absorbed from the skin. How much, I don't know. I don't know whether there's any really good studies that say how much is soil. There's also an article that came out in the British Medical Journal that should be a landmark as far as articles goes. It's open access. I'll give you a shot of the article. There it is. Okay, so there's the article. Came out in the British Medical Journal last week, which is called Mortality from Different Causes Associated with Meat, Heme iron, which is the kind of iron that's predominant in meat, nitrates, which are in meat, and various diseases. Actually, 7 different diseases are strongly associated with meat intake. And they talk about it being primarily associated with red meat intake. That's the main discussion. But there's lots of evidence, and they say so in this particular article, that chicken and fish are also culprits in giving people various kinds of diseases. So that's probably a worthwhile article to look up in the British Medical Journal. And let's see. Anyway, they talk about how there's an increased risk in heart disease, respiratory disease, yeah, and stroke, diabetes, infections, Alzheimer's, chronic kidney disease, chronic liver disease. Those are dramatically increased when people increase their intake of meat. And yeah. There's a nice editorial. I don't think that's open access, but there's a nice editorial with it.
That's correct.
Yeah, they're talking about cardiovascular disease, cancer, hepatic, renal. I mean, this is worldwide headlines. You would think that the meat industry would be quite upset about this. And I guess they can't say it's not true anymore.
No.
They've done that for a long time. They've just stood up there with their PR representatives, their spin doctors, and take something that is obvious and true and killing of millions of people, and they can no longer deny it. The evidence is so overwhelming, and this is the latest and largest study of the association of red meat and various kinds of diseases. So the British Medical Journal is where you'd find that. Let's see, what else do they say? Let's see, meat was rare and largely celebratory in Greece. You know, people say, well, people have always eaten red meat. Well, they rarely ate more than 5 to 10 kilograms of meat per person per year. I mean, that's in ancient times, 5 to 10 kilograms per year. Whereas now in Australia, New Zealand, United States, people eat 110 to 120 grams of red meat per year. So, I mean, there's, you know, when folks use the argument, well, we've always eaten meat as an excuse to eat meat that's not dangerous. Yeah, but they just ate a small amount.
Would that be pounds or kilos or grams? Kilograms. Okay.
Yeah, kilograms.
Yeah, that's an incredible increase. Huge.
Yes, and with the increase, we have a dramatic increase in the risk of dying of various diseases around the world. And of course, it's spreading to more and more populations. Mm-hmm. It's not just limited to Americans and Australians and people from New Zealand.
Not anymore. No.
We also talk a little bit about the environmental destruction from red meat. Red meat is the biggest destroyer of the planet of all stories I can think of is red meat. And you know, folks are starting to stand up and fight against the meat industry because they realize that it's not just their personal heart attack or liver failure or kidney failure or respiratory failure. It's also their children and grandchildren and future generations and so on. So I do see things that are really happening in terms of trying to help our planet and trying to identify and firmly state that red meat is a killer. From so many points of view, it's the wrong thing to do. So evidence is still coming out. It's coming out very consistently, incriminating meat. And it's not just red meat. It's fish and chicken, and other kinds of meat. So there's an important article that came out, and a little follow-up on the oil on the skin. It is absorbed. Whether or not it makes you fat, well, there's one study that I had, I must have dropped it someplace, about how putting polyunsaturated fats on babies caused them to gain weight. Just a very controlled situation where the only thing that was changed was adding rubbed oil on a baby's skin, and they gain more weight. So yeah, you gain weight when you put oils on your skin, and however, it's not a lot amount usually, and there is some blockage by the dermis, the skin, as far as absorbing this oil. But yeah, it is absorbed. Well, we're going to talk a little bit, Gustavo, today about colon polyps and colon cancer, right, from the Digestive Tune-Up book. But one thing I didn't talk about last time, which I don't really want to skip, is we talked about constipation last time, but I didn't talk about diarrhea. Diarrhea is one of the more fun problems for me to treat at my clinic. I have people who come in who tell me stories like, I haven't been out of the house for 2 years. I basically live in the bathroom with my computer and my TV and my telephone. And I poop 20, 30 times a day, watery stools. And they come in to see me at the clinic and they tell me their story. And I say, well, we'll fix that, usually within about 24 to 72 hours. And they just kind of laugh and they think I'm treating their problem not seriously. But I am treating it seriously. It was reported by Anderson back in 1973 that adding fat to the diet causes diarrhea. And the way it works is this, and we've discussed this before, but bear with me to repeat the explanation. What happens is some people can't absorb bile acids well. Bile acids are produced by the liver, and they're produced as a result of consumption of fat. The more fat you consume, the more bile acids you consume. Well, these bile acids that are made by the liver and then are injected into the small intestine, these bile acids are supposed to get reabsorbed in the last part of the small intestine called the ileum. Completely absorbed, so that they don't go into the large intestine and irritate the large intestine. Well, in some people, either because they have damage to the ileum or for some other reason, they produce these bile acids and they're not reabsorbed in the last part of the small intestine, the ileum. Instead, they pass on through into the large intestine. Well, bile acids are very irritating. So they cause irritation, which leads to mucus and diarrhea and watery stools. So when you change your diet, these are people with severe, chronic, debilitating diarrhea, colitis. When the people change their diet to the kind of diet that I recommend, a starch-based diet, very low fat, what happens is the liver produces far fewer bile acids. And the result is the diarrhea stops. Anderson reported, as I say, in 1973. And, every medical student should know this. Every doctor should know this. Every person should know this, that their chronic diarrhea can be rid of by simply changing the diet and getting the fats out and reducing the production of bile acids. And it goes away. But the problem is when you break your diet, when you eat fatty foods, what happens is the reaction is immediate. You get something called McDougall's revenge. And you go from 2 form stools a day back to 20 watery stools a day. So that's a form of colitis due to bile acids. There's also an autoimmune disease called inflammatory bowel disease, ulcerative colitis, Crohn's disease. Inflammatory bowel disease is the general name of this condition of the primarily large intestine, which is very inflamed. The intestinal wall gets very thick, all kinds of sores and, pus and just a terrible reaction. And it's an autoimmune disease where the body attacks itself. And what causes the body to attack itself is something in the Western diet, because these inflammatory bowel diseases don't exist in populations that eat similar to what I recommend, a starch-based diet. No dairy, very little meat. There's no such thing as ulcerative colitis or Crohn's disease in those societies. Of course, those societies are disappearing quite rapidly, so it's hard to find them anymore. But once you have ulcerative colitis or Crohn's disease or any other inflammatory bowel disease, whatever you want to name it, it doesn't matter. You're just putting it in a category. When you change the diet, what happens in most cases, this has been my experience, and we have star McDougall's on our website that tell this story, that what happens is that the inflammatory disease quiets down dramatically. The diarrhea goes away within 24 to 48 hours, as I mentioned with Crohn's. But the whole inflammatory bowel process takes about 4 months to heal. And so the person starts out with a very irritated gut, and anything they eat or maybe even drink water causes them to have a reaction until the inflammation calms down. And it takes a while. It takes maybe 4 to 7 days to start things calming down once you start a new diet. And the diet I start is the basic McDougall diet, but I also start gluten-free, and I start without soy. People ask, well, why do you start without soy? Because people get into such nasty soy products so easily, which are isolated soy proteins like soy hot dogs and soy hamburgers and soy bacon, etc. It's so easy for people to get into fake foods that I generally start out with all autoimmune diseases. I start out with a McDougall diet, starch-based, but not with wheat, barley, and rye, which are the gluten-containing foods, or high gluten foods, and also the soy foods. So I start people out there, and about 4 to 7 days later, they start to get better. And then as time goes on, it may take longer for some than others. Usually within about 4 months, what happens is everything quiets down, and you're essentially free of the disease. And I've seen this over and over and over again to solve serious, these are deadly diseases, these inflammatory bowel diseases, certainly debilitating. But a change in diet will change that. And I've seen it almost every time that I've seen somebody change their diet. Give it a try. Take the challenge. If your friend has one of these conditions, either chronic diarrhea, like we first started talking about, or actual severe inflammation of the bowel, like ulcerative colitis and Crohn's disease, get somebody to try it. Just challenge them. Just tell them, look, do it for 2 weeks. Strictly, and see what happens. If you get them to accept that challenge, they might find out something really important, and that is what you put in your bowel. Let me say that again. What you put in your bowel has to do something with your health. However, if you ask most physicians, even today, this should have disappeared 50 years ago. Even today, doctors, when you mention diet, they say diet has nothing to do with disease. And you look at them like, okay. Obviously, looking at you, being 75 pounds overweight and sickly looking, you believe diet doesn't matter. Sad to say that's where our medical business is based, is even though doctors are thinking more and more about diet, they really don't get it. And as a result, they really can't counsel people on how to solve dietary diseases, how to stop angina, how to slow cancer growth, how to cure type 2 diabetes. Doctors never mention this. It's because they weren't trained that way, so they don't know anything about it. And you know how it is with people. If I don't know about it, it can't be important. And there are a few exceptions. There are some young doctors who are coming up and starting to take care of the patients by fixing their diet first, and secondarily supporting them with medications that may be more good than harm. So that's what I missed talking to you about. And the next thing I was going to talk to you about, which is chapter 11, which still gives us a couple more chapters to talk about in Dr. McDougall's Digestive Tune-Up.
Right.
What we were scheduled to talk about was colon polyps and colon cancer.
Right.
The colon polyps develop as a result of irritation. The body responds to irritation in a couple of ways. The skin cells, squamous cells, when you irritate them, you irritate them like this, what happens is they develop a callus. Like a callus, kind of a carrot looking like structure. It's a callus, and it's from chronic irritation of the skin. That's the way the squamous cells or the skin respond to irritation. The intestinal cells, as well as the cells of the uterine cervix and cells of the mouth and so on. The intestinal cells, nasal mucosa, they respond. They're smooth muscles, or they're mucus cells, is what they are. And unlike squamous cells, the way they respond to irritation is they just proliferate. And so you irritate the mucosal cells of the large intestine, say, and what happens is they start to proliferate to respond to the stress of the irritation. And so it may produce just 2 or 3 cell layer thick mound, and you can't see that. And then it continues to proliferate because of continued irritation. And finally, that mound of proliferation is big enough to see, and we call that a polyp. And then the irritation continues, and the irritation continues. And the longer the irritation continues and the more severe it exists, the irritation, the more likely it is for it to evolve into a cancer. So it turns from a polyp. It usually is a centimeter in size before it makes this change, and then only 1% make the change. When it's 1 centimeter size or larger, then you have a 1% chance of that polyp containing a cancer. And as it further becomes irritated, the risk of it being cancer becomes even higher from that chronic irritation. So what you want to do first of all is you don't want to start the proliferation. You don't want to have the irritation going on. The irritation's from the food. It's a result of consuming meat, which our intestine really isn't designed to handle in any large amount. You want to not put the things in that cause the irritation, that cause cells to proliferate, which cause some of them to turn into cancer, which can kill you from colon cancer. And of course, the diet to eat to make the intestine happy, what the intestine is designed for, is a diet of starch with the addition of fruits and vegetables. Yes, I understand. The body can tolerate amazing things. It can tolerate pepperoni pizza. It can tolerate beef sausage. It can tolerate anything for a while. For a lot of people, not most, because most people get very sick from Western diseases. So you want to eat a starch-based diet, minimize your meat intake, probably 0. And that's the way you want to deal with colon cancer, is not get it. Once you get it, can you do anything about it? Yeah, you can. You can cut it out. And that may make a difference in you dying from colon cancer, but it doesn't make a difference from your risk of overall death. It's still the same. So you can cut it out. You can burn it off. In fact, there's a very interesting study that's on my website about treatment of colorectal cancer with a wart burner. You just burn it off. And this is still done with people too old to have surgery. They go in with a wart burn and they just burn the tumor off. Now, there's a particular location of the tumor that is really difficult to treat. And that's in the last part of the rectum, the first part of the anus, anal rectal cancer, we call it. And to remove that is a very difficult job. I remember doing it. I used to be a surgical nurse. That's how I put myself through medical school, is working in an operating room as a nurse, helping people do surgery and get through surgery. And the one particular procedure we did was an anal rectal resection. And this is done by two teams of surgeons. One starts from the belly, through the belly button, and the other team starts in the bottom, in the rectum area. So you got two teams working together to cut the intestine out from the anus up to, far enough above the tumor. You got to cut that section out. Well, in one part of the operation, usually about an hour in, as they make this connection, one team reaches through on the bottom, from the bottom, the other from the stomach, from the abdomen, and they meet together. And what they do, characteristically, I'll never forget this. I mean, this is very disrespectful, but doctors need a sense of humor. Being in that operating room, dealing with all these problems is pretty stressful. So what happened, as I remember it every time, is the teams of surgeons reached through the person's body and shook hands during the operation. Yeah, that's how severe the operation was. And then, of course, they had to sew them up and put a colostomy bag on them and so on. Well, the results of that kind of surgery, this AP resection, this rectal anal resection, the results were, compared with burning the tumor off with a wart burner, which takes a few minutes, very little anesthesia. You just go in there, you just burn it off down to its roots. The difference in mortality is 1 year. 1 year in favor of the wart burner. But how many people are told that? Well, only if you're too old to go to surgery are you told, well, we can do this with a wart burner and, make it an outpatient procedure. So anyway, if you're found to have colon cancer, you should have it removed. And it'll reduce your risk of dying of colon and rectal cancer, but not overall death, because some people will die on the operating table. And you need to change your diet. Now, to look for this information, go to my February 2015 newsletter. And it's a whole section about diet and cancer. And it tells how on February 13, 2015, the American Cancer Society came out and officially recommended that once a person gets breast, colon, prostate cancer, they should change their diet towards the diet I recommend. Why? Because survival is prolonged. Yeah, February 13, 2015, they published that. Now, how many doctors practice that way now? I doubt. Probably count them on one hand who tell their patients forcefully, you've got breast cancer, colon cancer, prostate cancer. If you change your diet, the scientific research proves beyond a doubt that you will live longer. You can read all the references there. They're all linked. You can just click on them and read the studies. Boom, 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 boom. And you'll see that you can change the course of these cancers, including colon cancer. So you want to change your diet, folks. The idea that what you put in your bowel, your intestine, has nothing to do with its health is just beyond crazy. I mean, how could anybody really come to that conclusion? Particularly an intelligent person like a physician who is well educated and maybe has above the average number of smarts. But still, they deny to their patients the diet has nothing to do with hemorrhoids, colon cancer, polyps, ulcerative colitis, Crohn's disease, and on and on and on. It's obvious. I mean, how many of my listening audience now could really stand and look themselves in the eye or a friend in the eye and say, you know, what you put in your intestine, it makes no sense that it has anything to do with health or disease. We all know that you just need a well-balanced diet, you know, a well-proportioned amount of chicken, beef, pork, cheese. That's a well-balanced diet. Well, you know, that's not the case. So anyway, just to go back to my, what would be July 2016 newsletter about colonoscopy, my latest review on colonoscopy is it doesn't work. It has never been shown in a well-designed study to reduce the risk of dying of colon rectal cancer, much less overall cancer. And what I do recommend is I recommend that people get a stool test. There are several that can be obtained. You can read about this in my July 2016 newsletter. So you can get a stool test for blood or genetic material to suggest cancer as a screening. And this should be started around age 60 and not prolonged after age 75, if everything's fine. And you get it done, say, every 2 years. It costs you somewhere between $4 and $40 to get this kind of test done. Or you can get one sigmoid exam. One sigmoid, that's a short tube. That's like the 2-foot tube. A sigmoid exam, which can be done without anesthesia, can be done in just a couple of minutes. And that'll give you improvement in your risk of getting colon rectal cancer, not overall death, but colon rectal cancer with a sigmoid exam. So I recommend one sigmoid exam for the average person who's in relatively good health around age 60. And that's it. And if it's clear, don't get another one. So those are the two methods that I would suggest around age 60 to 75. You get a sigmoid and or stool test for blood to prevent colon cancer. But remember, food's the most important thing. So don't goof around. Just focus on what's going to make the real difference, and that is what you put in your mouth. And not only are you going to prevent heart disease, you're going to look trim and pink-skinned and be most active. So there's every reason to do the right thing. You need the knowledge. And of course, all the knowledge is there on our website, free. There's a quick start program we just put up there. And that's a program that talks about my basic talk, Dr. McDougall's Color Picture Book on food poisoning, and also 2 talks by Mary, one on planning meals and one on eating out. And so those are 3 hours. If you get somebody to sit down to and watch for 3 hours, you'll understand the program, and really well. And then you go and rewatch it over and over again. I think my audience should be watching Mary's meal planning once or twice a week or more, because it's an amazing amount of instruction. Well, anyway, I think I probably covered everything I routinely plan on covering today, Gustavo.
Very good.
Do you have anything that our listeners are interested in?
Yeah, well, I think that what you mentioned about the newsletter, we need to make sure that people understand that your newsletters have those links where they can go directly to the source, and it's invaluable information. They can print those articles. They could potentially take them to their doctor, whether they look at them or not. That's another story. But
well, that's the doctor's job, and sometimes you have to challenge the physician because they're busy. Doctors are busy writing the checks, paying the bills. They're busy seeing as many patients as they can in an hour. The average visit is 7 minutes, probably total of 10 to 15. So the doctor can see 4, 5, 6 people an hour. And, money is time. To dedicate a half an hour to teaching a patient about good food doesn't make a lot of sense. In fact, you shouldn't have to do it. What I encourage physicians to do who are interested in teaching their patients about good diet is see them as individual patients. See them every 7 minutes to adjust their medication, a 7-minute period of time. see them at that interval, and then just tell them, look, we're going to have a meeting here at my office with 40 people and talk about diet. And that's just part of your visit. So I can't do individual teaching. It just is too time consuming. But what I would love to do is get together with you kind of for a social hour and talk about food and what to do to change and get healthy and so on. And then as you get better in your diet, you come back every week or every 2 or 3 or 4 weeks, and I'll adjust your medication because you're healthier. You've lost 10 kilograms, and your blood pressure is so low, I'm afraid you're going to fall down. The doctor has to adjust the medications, and that's done during the 7-minute office visit.
Right. Dr. McDougall, someone is asking about if you know anything about the Cologuard test and what does this DNA test actually find?
I know a little bit about it, probably not as much as they do about it. But it's a new test came out, I think, 2 years ago. And it's a genetic test. It costs about $600 to get. And I'm not sure whether you need a physician's order to buy one of these kits. But what it does is it checks for DNA in the stool. And it shows DNA that has been converted to polyps or converted to colon cancer. And it comes up positive in that test. Now, again, this is a $600 test. Stool for blood is like $4. I don't know that Cologuard is any better. In fact, I suspect it's not any better at saving lives than is, say, just checking the stool for blood. But it's an interesting new test, and if you can afford it and you want to get both, fine. I can't say there's no harm to checking your stool, unless, of course, you find something. Then you got to deal with that whole trail.
Right. Once you find something, then
that's the sad thing, is that you may save a few lives. Maybe one in every 1,400 exams, good exams you do, you pick up somebody with cancer that you change their kind of death, maybe even their day of death. But that's maybe 1 in 1,400. At the same time, when you do some tests like colonoscopy, you end up killing 1 in 1,400 people. Perforation of the bowel on the table while you're doing the colonoscopy exam. That's the problem. Maybe colonoscopy does save lives. Maybe it does. But it's also a highly dangerous procedure done with anesthesia. The risk of severe complications when polyps are involved is about 7% of the people. Serious bleeding or perforation or other problems. So this is a pretty big deal. You'll know in retrospect when you get to be 70 or 90 and you don't die of colon cancer, you made the right choice not to get a test. If you find a colon cancer, you're going to have it removed. I mean, I wouldn't recommend otherwise. You have to have it removed and get on with your life. Well, you don't. I mean, you're the customer. You don't have to have it removed. You can say, I'm not going to do it.
Right.
And likely it would make, I know it would make no difference in your risk of dying. I mean, that's been proven. It'd make your risk of dying of colon cancer less, but not overall death, because remember, there are complications just from the testing that are as severe as death, perforation, death.
Very good. Dr. McDougall, a question that someone sent in by email that says, I had 3 polyps removed during my only colonoscopy at age of 61. Also have a diverticula, and I am advised to repeat in 5 years. Can I forego this test if I stay on the McDougall diet?
Whether or not you stay on the McDougall diet, there has been no testing done to show that repeating a colonoscopy 3 to 5 years after finding polyps reduces the risk of dying. It may seem obvious to somebody that, once you've had polyps, you're more likely to have more polyps and more likely for them to degenerate into cancer. But going from that logical thinking to the idea that once I've had polyps, if I have them checked more frequently, I'll be more likely to find them precancerous and more likely to save my life. It's not true. Because remember, every time you have one of those repeat exams, you're going to have a colonoscopy, which means you're going to have a 7% major chance of a severe complication and maybe a 1 in 2,000 chance of dying of perforation. So, remember, if you get it every three years, that's the risk coming up every 3 years. So if you ask your doctor for evidence that once you've had polyps, if you get a repeat colonoscopy, say 3 years later, which is a standard recommendation, or 5 years later, but some doctors 10 years later, if you follow the standard recommendation, ask the doctor to show you evidence that you will live longer than those who don't have follow-up examinations after polyps. I couldn't find any, but it's a good guess, and it's safer to guess. More treatment results in better outcome, even though you end up killing people, because who's going to sue you for killing them in the effort to save their life? And so doctors get away with it. They don't have to provide the evidence that repeat colonoscopies are going to save their lives. Now, they may, but nobody has the data to show so. So in answer to your question, whether or not you should get a repeat colonoscopy because you've found polyps, whether or not you follow the McDougall diet, we don't know that it makes any difference. However, if you eat the McDougall diet, you should stop forming polyps, and the ones that you have should regress. There are actually studies which I have. I have this basement cabinet of tens of thousands of articles that I collected over the years. And there's actually one research paper that I have which shows people with polyposis, tremendous number of polyps in the colon. So many polyps that for one reason or another, they couldn't take that part of their colon out. And so what they did is they diverted their small intestine out their abdomen through a ileostomy, a bag, so that no more feces material went into the large intestine. And what happened was the polyps regressed. They went away. And I have that research someplace down in the basement that talks about people with these severe polyposis who, when they diverted the flow of intestinal contents away from the large intestine, the polyps disappeared. So I believe, I don't have the proof that I would like to have for you. I believe that changing your diet, even if you have polyps, will cause them to go away. And all my experience says that. But it's not extensive experience, so yeah, you could prove me wrong. But it makes all the sense in the world. It's just like when you have a bad cough and you're a smoker and you quit smoking, what happens is the cough goes away. It's just the way it is. When you stop irritating a particular part of your body, then it stops responding by serious coughing and wheezing. Same thing with your intestine. If you coat your intestine with healthy food like potatoes and rice and corn, then what happens is it's not irritated anymore. And as a result, the polyps go away. That's my experience. That's what I believe. But it only makes sense. Even if it doesn't, it only makes sense if you believe that what you put in your colon causes colon cancer, for you to change your diet.
Right.
Even if they won't regress. I mean, why not? It may be a warning that saves your life from a heart attack or breast cancer or a stroke. Just knowing you have polyps and that they're caused by bad food and fixing the food may fix the polyps. But it'll at least cut your food bill by 60 to 80%. It'll at least give you a great bowel movement instead of the constipation you've been suffering all your life. So there's no reason. It's environmentally, cost-wise, it's personally helpful, and you change your diet.
So in your
and then if you want, you can go back and recheck. Say you were diagnosed with polyps now, you change your diet, and you need to have reinsurance because Dr. McDougall is Dr. McDougall. He's got his own opinions, so you need reassurance. So go in and get a repeat exam. What would I get? Well, sigmoid at most, and maybe Cologuard to give me some reassurance that I don't have polyps growing again. I think that would be reasonable, safe, as long as you're resistant enough to say, no, I'm not going to do any more further testing. If you do find something suggestive, you got to make up your mind, because once these things happen to us, then we're put in a situation where it's hard for us to say no in terms of doing more. You're afraid, and there's every reason to be afraid. But when you're afraid, you want to look to answers that are true. And the truth is that the answers that are being given, such as repeat colonoscopy 3 to 5 years after a polyp, or you'll save your life with a colonoscopy, plain and simple, aren't true. So they're not telling you the truth.
Right. Dr. McDougall, if someone who hasn't never had a colonoscopy and they're 73, 75 years old, would you say that they need to have one, or?
No, never a colonoscopy, unless it's for diagnosis, not for screening,
right?
Not for looking for cancer. I never recommend a colonoscopy. I would never recommend it to anybody unless there was a specific reason, like they had obvious disease, bleeding, or other thing that needed to be directly investigated with a colonoscopy. And it's a great tool. But as far as going out and taking healthy people off the street and sticking a 6-foot tube up their butt, more harm than good is done. Far more harm than good.
Right.
And the expense is huge if you had to pay for it.
Right. Well, I mean,
will I pay $4 to check my stool for blood, or will I pay $3,000 to have a colonoscopy done? Well, let me see. Now, let's see whether or not I want to buy that new car, or that new set of clothes, or get my butt poked. What would I rather do? Especially since neither results in improved mortality. Maybe reduction of risk of colon cancer. Yes, reduction of colon cancer-specific death.
Right.
But not overall mortality. Remember, testing kills.
Well, that's what you said. It's very important. I hope people heard you say that there's a difference between diagnosis and just screening.
Right. Let's say once you find evidence of polyps, say with blood or Cologuard, or if you have a sigmoid exam done, you have some problems. That's not screening anymore. You're already found to have disease or evidence of disease. And so you're not in a screening procedure anymore. You're in a diagnostic procedure. Now the doctor has to go in and see what is the source of bleeding. Why is Jane bleeding? I have to stick this tube up her butt to take a biopsy and to give her a diagnosis, and then tell her what the options are. Chemotherapy doesn't work. Radiation doesn't work. And removing the tumor seems to work.
Right.
As far as dying specifically from colorectal cancer. But remember, the last time I'm going to say it, testing kills.
Yeah. Thank you, Dr. McDougall. In one of the webinars we've done a while back, you talked about coffee enemas. And people are asking about that, and coffee or alcohol. So I just want to say, go to Dr. McDougall's website, type in the search engine all the information is there, unless you want to say something about alcohol and coffee enemas and everything like that.
Well, okay, coffee is not health food. Alcohol is not health food. No matter what you'd like to hear, it's not health food, and it has significant adverse effects. So, be real. Now, as far as coffee enemas go, I don't know much about coffee enemas, except I have known Charlotte Gerson and I've actually known Charlotte Gerson about Max Gerson. Max Gerson wrote a book in the 1940s called 47 Cases of Cancer Cure. And so it's a blue book, and it was presented before Congress of 48 cases, or 48 cases of people with cancer all over the body who changed their diet toward a diet like I recommend, who I believe gave extra thyroid medication to increase the metabolism, and also offered coffee enemas to kind of clean out the intestinal tract, to detoxify the body. And coffee enemas have been a part of their treatment plan. Coffee, of course, obviously irritates the intestine even when you put it up through the bottom side. Whether or not this is of great value, I can't tell you. I don't have the experience, but that's part of their program. And the Gerson program is one I've always had a lot of respect for in terms of if somebody asks me, like, I have terminal cancer, should I consider the Max Gerson treatment? And the answer is, why not? I don't know whether it works or not, but it certainly doesn't do the harm of chemotherapy. And anyway, the coffee enemas may be part of the solution, but I can't prove it for you.
All right. Well, Dr. McDougall, I think we're going to close the webinar. I have to go back to work. And I know that there are other questions here. I just want to mention that the questions that you send by email, everybody, they're collected and then they're sent to me. But if you send them the morning of the webinar, they're probably not going to get to me. So please, if you send the question and it wasn't asked, resend it for next week, and I'll probably get it to them.
That'd be good. The only other thing I want to put out notice to people is that our June 2nd, 2017 10-day program is entirely sold out. So we can't take anybody new in June, but you can get on a waiting list. We're completely full for June 2nd, 2017. And then the next program after that, I think, is in August, and we still have a few places open there, but that's rapidly filling up too. So, I'm glad, because this is what I love doing, and Mary loves doing, and the rest of the team, Doug Lyle and Jeff Novick, and the rest of us really have such a good time with about 50 people.
Yes.
Many times a year, many times. I was going to say 6, but it's actually at least 8 times a year we get a chance to get together with between 50 and 150 people and take care of them. Often it is just myself and Dr. Anthony Lim that take care of the patients. But we have big programs. So we have programs for CenturyLink, which is the big telecommunications company. We'll have 120, 140 people, and I'll have 5 physicians, well-educated, very effective physicians who work with us to see all the patients. So we want to kind of see 120 people in one day. And as a result, we're bringing some other fine doctors. But that's a private program. The CenturyLink and Whole Foods program are both private, so outside folks can't get in. But our other programs, we limit it to 50, and June's full. We want to see in August or September or whenever the next week you can attend is. Dr. Lim and I are there to help. Whether there's sports, you give you the answers. And, but again, everything's free on the website. Don't forget the Quick Start program. Anyway, Gustavo, as always, you were a wonderful host. And maybe we got to turn a few new people on today.
Well, thank you. And I apologize for Jay here, who's saying that I have been nodding my head for an hour. I'm sorry about that. But I agree with Dr. McDougall. So, Dr. McDougall, thank you so much for today. And we'll see you next week. We'll continue.
Next week, we'll probably talk a little bit about bad farts.
That's right.
Yeah, probably do that and talk a little bit about, a couple other things. Maybe we'll talk about gluten. I don't know. But maybe something exciting will come up this week.
Yes.
There's always news. The thing is the news always confirms the past, because what's true is true, and it doesn't change. Even though this report on deaths related to red meat intake came out just this has been reported for 50 years or more. In fact, it's reported since 1950. So anyway, well, that'd be 50.
Very good. Well, thank you for making the time to be. Okay, we'll see you all next week. Thank you. Bye-bye.